Welcome to Deep Dive Ortho. We're all seeing this, aren't we? This incredible surge in youth sports participation, kids specializing, well, really quite young now, often year round. But what's the hidden cost? Especially for those developing bodies, what are the consequences of such intense engagement? Today, we're doing a deep dive into something that's become increasingly prevalent, certainly in pediatric orthopedics and sports medicine: Little League elbow. Now, this deep dive is designed specifically for you, our medical professional listeners. We want to move beyond just the surface level information. Our mission today is to really uncover the underlying mechanisms, those diagnostic nuances, and the multifaceted management and prevention strategies that you need in your daily practice, really equipping you with practical, actionable insights. And to guide us through this, well, quite intricate topic, we are incredibly fortunate to have Professor Mo Imam joining us. His insights into orthopedic conditions, particularly in young athletes, are truly invaluable. Welcome.
Thank you very much. It's a pleasure to be here. And yes, it's a condition that really represents a significant and, I think, growing challenge in modern sports medicine.
Professor, let's start by laying a really precise clinical foundation. We all use the term Little League elbow, it's common parlance, but it isn't actually a single injury, is it? For our audience of medical professionals, what's the most precise, clinically relevant definition they should be working with, especially understanding its multifaceted nature?
That's a really critical distinction to make right from the outset. Little lead elbow. Well, it's unequivocally not a singular injury. Instead, you should think of it as encompassing a continuous spectrum of overuse conditions. And these all impact the medial or the inner side of the elbow. And its heart, it's really a consequence of repetitive microtrauma to the developing elbow joint. So it's a cumulative effect, not usually an acute, isolated event.
Right.
And this spectrum can present in several ways, each with its own clinical implications. The most common manifestation, particularly in our younger, skeletally immature patients, is medial epicondyle apophysitis. Okay,
Right.
this is essentially an inflammation or irritation of the growth plate, the apophysis, located on the medial epicondyle, right where those important muscles and ligaments attach. However, the condition can also progress, unfortunately, to include more severe pathologies, things like medial epicondyle stress fractures or injuries to the ulnar collateral ligament, the UCL.
The crucial stabilizer.
Yeah, like the crucial stabilizer, and even strains of the flexor pronator muscle mass, which originates from that same medial area. Now, the specific presentation, it often correlates directly with the athlete's age and their skeletal maturity.
Ah, interesting.
Yes. For example, a younger patient, maybe an 8 or 9-year-old, they're far more likely to present with that apophysitis or perhaps an acute avulsion injury of the growth plate where a small piece of bone is actually pulled away. In contrast, significant UCL sprains or even full tears, well, they tend to be observed more often in older, more skeletally mature adolescents. Their ligaments are relatively stronger compared to their growth plates, which might be starting to fuse.
So it's that gradual breakdown under chronic, repetitive stress rather than one big traumatic incident.
Precisely, it's the accumulation of microdamage.
And it certainly feels like this is a problem we're encountering much more frequently now. What's fundamentally changed in youth sports that seems to be driving this, well, quite concerning trend?
You've highlighted the precise concern. The rise in incidence of Little League elbow is, frankly, alarming. What we're witnessing now are young athletes, some still pre-adolescent, developing the sorts of injuries that were once almost exclusively associated with older, more experienced, often professional baseball pitchers.
Mm.
And this profound shift, well, it seems to be a direct consequence of the escalating demands placed on young bodies within modern youth sports culture. We're seeing year-round competition, which completely eliminates those crucial off-season rest periods. And there's this pervasive trend towards single sport specialization at increasingly younger ages.
Right, playing one sport intensely all year round.
Exactly. Without the variety or the breaks that allow their developing musculoskeletal systems to recover and, frankly, adapt properly. Consider some data from a large retrospective analysis. They looked at 317 subjects diagnosed with Little League elbow. The mean age was 12.8 years, but the range spanned from 8 right up to 16 years old.
Wow, quite a range.
It is. And what's particularly striking from a demographic standpoint, 98% of these subjects were male, and an overwhelming 98% were baseball players, primarily pitchers.
Okay, so predominantly young male pitchers.
Overwhelmingly so. Although, while baseball is dominant, we do, albeit rarely, see this condition in other overhead athletic populations. Tennis players accounted for 1% of cases in that study. American football quarterbacks also about 1%. But yes, adolescent and pre-adolescent males are disproportionately affected, especially during those periods of rapid growth spurts.
Why then specifically?
Well, it's because the unique stresses placed on their developing bones, particularly the open growth plates, during that repetitive throwing motion, make them inherently vulnerable. Their growth plates simply lack the same resilience as mature bone or fully developed ligaments. They become the weakest link, if you will, under that repetitive loading.
Okay, so we've defined the condition, noted its concerning rise, particularly in young male throwers. But to really understand why these young bodies are breaking down, we need to get into the physics, the biomechanics of the throwing motion itself. Could you walk us through those fundamental forces at play, specifically this concept of valgus overload?
Of course. Yes, to truly grasp Little League elbow, understanding the core biomechanical mechanism is key, and that is repetitive valgus loading in the elbow during the throwing motion. If you imagine the elbow bending outwards, away from the body, that's the valgus force. It's like opening the joint on the inside.
Right.
This force creates immense, what we call tension overload on the medial aspect, the inside of the elbow. Now, this tension isn't constant through the throw. It's most pronounced during two critical phases. Firstly, the early cocking phase, as the arm is preparing to accelerate forward and outward. And then again, perhaps even more so during the late cocking phase. This is just before the ball is released, as the shoulder and arm are externally rotated to their absolute maximum extent.
Maximum stretch on the inside structures then.
Exactly. And this repetitive microtrauma, occurring literally thousands of times over a season, especially to an immature skeleton with those open growth plates we mentioned, is the primary driver of the injury. It's that cumulative effect. Each throw contributes a tiny amount of microscopic damage. And without sufficient rest and recovery time, the body simply cannot repair this damage effectively. It leads to an accumulation that eventually overwhelms the tissue's capacity, resulting in inflammation, pain, and ultimately structural breakdown.
And which specific anatomical structures are bearing the brunt of this tension? Where does this overload typically manifest itself first?
Well, the structures experiencing the significant tension are precisely those on the medial side of the elbow that form part of that LLE spectrum we discussed earlier. Foremost, especially in the younger athletes, is the medial epicondyle apophysis, that growth plate area. It's highly vulnerable. Then there's the ulnar collateral ligament, the UCL, which is, as you said, a critical primary stabilizer against that valgus stress. And finally, the flexor pronator muscle mass, that group of muscles originating from this medial epicondyle, also endures considerable tensile forces during throwing.
Okay.
Now, continuous repetitive tension on these structures can instigate a whole cascade of issues. Initially, microtears, inflammation manifesting as apophysitis or maybe tendinitis. And if that stress persists, well, you can get more severe structural damage. This can range from bony avulsion fractures of the epicondyle, where the growth plate is pulled off, right through to partial or even full-thickness tears of the UCL. The body tries to adapt, tries to reinforce itself, but often the repetitive load just outpaces its reparative capacity.
So the medial side clearly bears the tension, but given the sheer complexity and force of the throwing motion, are there other parts of the elbow that are also under significant stress? Things that clinicians need to consider. It's rarely just about one isolated area, is it?
Indeed, no. It's a testament to the immense and multidirectional forces involved in throwing that really the entire elbow joint is subjected to considerable stress. While medial tension is absolutely the hallmark of Little League elbow, we must consider the other aspects as well. So on the lateral or the outer side of the elbow, significant compressive forces are exerted.
Compression on the outside, tension on the inside.
Precisely. This compression occurs particularly during the late cocking and early acceleration phases, as the radial head, which is on the lateral side of the forearm, forcefully compresses against the capitellum, part of the humerus. Now, this repetitive compression can lead to conditions such as Panner's disease, which is an osteochondrosis of the capitellum, essentially a disruption of blood supply to that growing bone end. And also osteochondritis dissecans, or OCD, affecting both the capitellum and sometimes the radial head. These conditions involve the breakdown and potential fragmentation of the articular cartilage and the underlying bone due to that repeated impact. They often present with pain, clicking, sometimes even mechanical blocking or locking of the joint.
Right, loose bodies potentially.
Potentially, yes. Furthermore, the posterior aspect, the back of the elbow, is also vulnerable. The extreme, rapid extension of the elbow that occurs during the deceleration and follow-through phase can lead to what we term posterior injury patterns. This can include things like olecranon apophysitis, inflammation of the growth plate at the very tip of the elbow, the olecranon process, or posteromedial impingement, where bony spurs or sometimes soft tissues get pinched at the back, inner aspect of the joint, often causing pain and limiting full extension. And in chronic, maybe untreated cases, you might even see the development of flexion contractures or capsular thickening, which ultimately limit the elbow's ability to fully straighten, compounding the functional deficit. So yes, these are all part of the complex clinical picture that a really comprehensive evaluation must consider. It's not just the medial side.
It's clear then this single throwing motion generates incredible, multifaceted stresses throughout the entire elbow joint. But this isn't just a random event, is it? It feels like certain athletes are more predisposed. Professor, what are the key risk factors that really amplify this vulnerability for our young throwers, for our clinicians listening, and perhaps parents too? What should they be acutely aware of?
You've hit on an absolutely critical point. There often seems to be a confluence, a sort of perfect storm of factors that significantly increases a young athlete's vulnerability to little league elbow. And understanding these is paramount for any clinician aiming for prevention or early intervention. Firstly, and perhaps most critically, is poor throwing mechanics. Improper biomechanics during the throw dramatically elevates the torque and force placed directly on the elbow joint.
How so?
Well, when an athlete relies too heavily on just their arm strength, rather than effectively leveraging proper kinetic chain sequencing, generating power from the legs, transmitting it through the core and trunk, and then efficiently transferring it to the shoulder and arm, the elbow ends up bearing a disproportionate and frankly excessive load. Teaching and reinforcing correct body rotation, core engagement, and efficient energy transfer is absolutely crucial to distributing these forces more safely across the entire body.
Right, using the whole body, not just the arm.
Precisely. Secondly, overuse and insufficient rest are primary culprits. And this isn't just about the total number of throws, although that's important. It also encompasses doing too much too quickly. Perhaps a sudden ramp up in intensity or volume for a tournament, or simply not allowing adequate recovery time between throwing sessions, practices, and games. The modern trend of year-round competition and that early sport specialization means young athletes often don't get those natural restorative off-season periods. Without these breaks, the microtrauma just accumulates faster than the body can repair it, leading to a relentless breakdown. And it's also vital to note, a history of previous elbow or perhaps shoulder injuries is a significant predictor of future injuries. So any prior issues should raise immediate red flags for closer monitoring.
Okay, mechanics and overuse. What else?
And thirdly, we absolutely must factor in growth plate sensitivity. In our skeletally immature athletes, their open growth plates, the apophyses, are inherently softer and structurally weaker compared to the mature ligaments and tendons surrounding them. This means that under repetitive stress, the growth plate often becomes the weak link. It's far more likely to be injured, potentially leading to inflammation, widening, or even fracture, rather than the adjacent, stronger ligaments sustaining a sprain. This unique vulnerability of the growing skeleton makes young athletes particularly susceptible to overuse injuries in areas with active growth plates, like the medial epicondyle.
Those are very clear predisposing elements. But are there any specific quantifiable metrics or activities that serve as really strong indicators of increased risk? For our listeners in the clinic, what's the most impactful way they can perhaps use these specific metrics to guide those crucial conversations with parents and coaches?
Absolutely. And this is where we can move from general principles to concrete, evidence-based risk factors. These should serve as, well, almost non-negotiable red flags for clinicians, parents, and coaches. When you see these numbers, you know the risk profile is significantly elevated. For instance, throwing greater than 80 pitches per game has been consistently shown to significantly elevate stress on the developing elbow.
80 pitches per game, okay.
Another major factor is engaging in competitive pitching for more than 8 months per year. This really highlights the detrimental impact of that year-round play, eliminating adequate off-season rest, which is so crucial for both physical and mental recovery. And for those athletes developing higher velocities, throwing fastballs at speeds consistently exceeding 85 miles per hour places immense, almost exponential strain on a developing elbow joint.
Right.
But perhaps the most critical and universally applicable indicator is this: continuing to pitch despite experiencing arm fatigue or pain.
That sounds obvious, but...
It sounds obvious, but it happens all the time. This isn't just a risk factor, it's a direct signal from the body, practically screaming for attention, for rest. Ignoring this warning almost invariably leads to more severe, more protracted injuries. It turns apophysitis into a stress fracture, or worse. Finally, while participation in showcases might seem like a necessary path for exposure, they often encourage exceptionally high volume and intensity of throwing in a very short period, frequently without the necessary recovery built in. This significantly elevates the risk profile for these young arms.
So for clinicians, these metrics, pitch counts, season lengths, velocity, and especially pitching through pain, these are really your earliest intervention points, aren't they?
Exactly. These metrics empower you to have data-driven conversations. You can talk about workload management, about mandated rest periods based on age and pitch counts, and about the paramount importance of listening to a child's body, even if that means missing a game or a showcase. It's about long-term health over short-term perceived gains.
So for clinicians in practice, when a young athlete actually presents, perhaps walks into your clinic with suspected Little League elbow, what are the primary signs and symptoms that should immediately raise your suspicion? What are they likely to report?
When a young athlete, typically a thrower, walks into your clinic, the most common and consistent symptom they'll report, or their parent will report for them, is localized pain and tenderness right on the medial side of the elbow. This pain is almost always exacerbated during or sometimes immediately after throwing activities. They might describe it as a dull ache that starts after a few innings, or perhaps a sharper, more acute pain specifically during the acceleration or ball release phase of the throw.
Okay, pain with throwing medially. What else?
Beyond pain, you should actively inquire about other significant symptoms. Swelling around the medial elbow is a frequent finding, sometimes subtle, sometimes quite obvious. We also often observe a reduced range of motion in the elbow. One study noted this in about 16% of subjects. Particularly, they might have difficulty in achieving full extension, fully straightening the arm, or maybe pain at the end range of flexion. And in more severe instances, the athlete might report a mechanical sensation, perhaps a feeling of locking or catching within the elbow joint. This could be due to loose bone chips, maybe from an avulsion or OCD, or other internal derangements interfering with smooth joint movement.
And can you help us understand the nuances of the pain itself? Does it always present in the same way, or are there variations clinicians should be listening for? And are there other associated symptoms that might accompany it?
The pain itself certainly has its nuances, absolutely. It can vary quite a bit in intensity and character. It might initially present as a rather subtle, dull ache, perhaps noticed only after prolonged throwing sessions or the day after a game. However, if the athlete continues to push through it, this discomfort can certainly progress. It might become sharper, more intense, consistently worsening with activity, especially during the throwing motion itself. Initially, the discomfort may indeed be intermittent, appearing only during or immediately after throwing and then resolving with rest. But if it's left unaddressed, the athlete might find the pain escalating, becoming persistent, perhaps even present at rest, significantly impacting their daily life, not just their sport.
And that impacts performance,
Right.
presumably.
Invariably. This persistent pain invariably leads to a noticeable decline in throwing performance. Parents and coaches might report a decrease in throwing accuracy or significant drop in velocity that's often a key sign. Beyond the pain itself, the athlete might also report a subjective loss of grip strength, or perhaps just a general aching sensation in the elbow that extends down into the forearm, even during everyday activities like opening a jar or lifting their school bag.
Okay.
Clinically, upon examination, you might observe visible signs, maybe some redness, warmth compared to the other side, and that definite localized tenderness upon palpation right over the medial epicondyle, or slightly distal to it. And it's crucial to understand that severe untreated cases can unfortunately progress to more serious complications, like a complete avulsion fracture, where that piece of the medial epicondyle is pulled completely away from the humerus by the ligament or muscle forces. Early recognition and prompt intervention are absolutely key to preventing such progression.
It's abundantly clear that Little League elbow demands a really holistic approach because, as you've hinted, it's rarely just about the elbow in isolation, is it? What other areas should clinicians be rigorously assessing for related issues when a young athlete presents with suspected LLE? This really brings us back to that vital concept of the kinetic chain.
You've hit on an absolutely crucial point there, the kinetic chain. It is truly imperative that clinicians perform a thorough evaluation of the entire kinetic chain, rather than just narrowly focusing only on the symptomatic elbow. You see, the powerful forces generated during throwing don't originate in the arm. They start in the lower body, the legs, and glutes. They propagate efficiently through the trunk and core, then transfer into the shoulder complex, finally culminating at the elbow and hand for ball release.
So a breakdown anywhere affects the endpoint.
Precisely. Any dysfunction, weakness, or inefficiency anywhere along this complex chain. Poor hip mobility, weak core, shoulder instability can lead to compensatory movements. And these often manifest as pathology at the elbow because it frequently becomes the weak link forced to absorb excessive load due to failures elsewhere. For instance, we frequently encounter concomitant ipsilateral shoulder pain in the same-sided shoulder as the affected elbow. This was reported in 13% of subjects in one particular study, highlighting just how common it is.
Right.
And a key finding, one that absolutely requires specific attention during your assessment, is glenohumeral internal rotation deficit, or GRRD. This describes a loss of internal rotation range of motion in the throwing shoulder compared to the non-throwing side.
And why is that so important?
Well, it was present in a significant 55% of patients with documented shoulder exams in one study. But critically, GRD was statistically linked to a significantly longer time from diagnosis to resolution of symptoms, with a p-value of 0.025.
So finding GIRD predicts a longer recovery.
Exactly. That GRD statistic isn't just an academic number. It's a critical clinical pearl. If you identify GRD during your examination, you immediately know you're likely dealing with a potentially longer, more complex recovery trajectory for that elbow pain. And your rehabilitation plan must aggressively target improving that shoulder internal rotation mobility and addressing the posterior shoulder tightness that often causes it. If you don't, you risk prolonged elbow symptoms and a higher chance of recurrence. Therefore, a truly holistic assessment that meticulously examines shoulder range of motion, rotator cuff strength, scapular stability, core strength, hip mobility, and even lower extremity mechanics is absolutely essential. It's vital for both accurate diagnosis and for designing a truly effective long-term management plan. Neglecting these related kinetic chain issues is a common reason for treatment failure or recurrence.
So we've gathered a thorough history, considered the kinetic chain, performed a comprehensive physical examination. Now let's focus on the diagnostic process itself. How do we effectively piece together this clinical picture when a young athlete presents with suspected LLE?
Right. The diagnosis of Little League elbow, as we've established, is primarily clinical. It relies heavily on that meticulous patient history, understanding the onset, nature of pain, training load, any previous issues, and, as you noted, a thorough physical examination. The hallmark physical finding, the most consistent sign, is that localized tenderness right over the medial elbow structures, particularly the medial epicondyle apophysis or the origin of the flexor pronator group. And critically, this tenderness is unequivocally exacerbated by applying valgus stress to the elbow. When performing the physical examination, the clinician should carefully apply this valgus stress, gently opening the medial side of the joint, often at varying degrees of flexion, say 20-30 degrees, to mimic the dynamic forces experienced during throwing.
To reproduce their pain.
Exactly, to reliably elicit their specific pain, and also to assess for any instability. Now, it is absolutely crucial to note that any palpable instability or excessive gapping detected with this valgus stress compared to the other side suggests a more severe underlying involvement. It likely indicates a significant UCL injury that demands specific consideration and probably further investigation.
Right. What else is essential in the physical exam?
A comprehensive physical exam must also meticulously include a thorough assessment of the elbow's active and passive range of motion checking for full flexion, full extension, and also pronation and supination of the forearm. Any loss of motion is significant. We also need a detailed valuation of muscle strength, not just elbow flexion extension, but also wrist flexion extension and forearm rotation, comparing sides, and flexibility, particularly of the wrist flexors and extensors. And crucially, don't forget a detailed neurological assessment of the ulnar nerve. Given its proximity, running just behind the medial epicondyle, it can easily be irritated or compressed by swelling, inflammation, or bony changes associated with these injuries. Check sensation in the little finger and ulnar half of the ring finger, and motor function of the ulnar innervated hand muscles.
Right, Tynel's sign, maybe.
Potentially, yes. Tapping over the nerve might reproduce symptoms. And specific provocative tests are highly valuable clinical tools. The moving valgus stress test, where you apply valgus stress while moving the elbow through a range of flexion and extension, is excellent for dynamic UCL assessment. The milking maneuver is another test to stress the UCL. These are designed to precisely reproduce the patient's pain and, importantly, to assess the stability and integrity of those medial structures.
Given the variety of potential elbow injuries in young athletes, what conditions must clinicians carefully differentiate Little League elbow from to ensure an accurate diagnosis? It sounds like there could be several mimics presenting with very similar symptoms.
You're absolutely right. The differential diagnosis for medial elbow pain in a young athlete is quite broad, and it's essential to systematically distinguish Little League elbow, particularly the apophysitis component, from other elbow pathologies that can present almost identically. A misdiagnosis can obviously lead to inappropriate management and prolonged morbidity for the athlete. We must, for example, differentiate it from other causes of medial epicondyle apophysitis, perhaps an acute traumatic event rather than overuse, so that's less common. We also need to consider the full spectrum of ulnar collateral ligament injuries. These can range from mild sprains, which might respond well to rest and conservative care, to complete ruptures, especially in older adolescents, which might ultimately require surgical intervention. The valgus stress testing is key here. It's also vital to rule out potential acute fractures or stress fractures elsewhere in the elbow that might present similarly but demand entirely different management. For instance, an isolated osteochondral lesion or fracture of the olecranon, or perhaps a non-displaced fracture of the radial head on the lateral side causing referred pain, could potentially mimic the symptoms but would require a different diagnostic and therapeutic pathway.
What about things like nerve issues?
Absolutely. Primary ulnar nerve issues like cubital tunnel syndrome, although less common in this age group than LLE, must be considered, especially if neurological symptoms like numbness or tingling are prominent. Careful neuroassessment is key. Furthermore, we must always consider those less common but significant conditions we mentioned earlier, like osteochondritis dissecans, OCD, of the capitellum or radial head on the lateral side. While causing lateral compression pain, sometimes the presentation can be vague or refer medially, so a thorough assessment is necessary to meticulously rule out these conditions. This involves integrating the history, the physical exam findings, including careful palpation of all elbow structures, not just medial, alongside evaluating the athlete's overall health, their growth stage, and critically, considering that detailed analysis of their throwing biomechanics. Subtle mechanical flaws can often contribute to various elbow issues that might mimic classic LLE. The systematic approach ensures we pinpoint the true underlying pathology.
So, once that precise clinical picture is established through history and examination, what role do imaging modalities play? How do they help confirm the diagnosis and, importantly, determine the extent and severity of Little League elbow?
Imaging plays a crucial, though often supportive, role. It helps confirm the clinical suspicion, and importantly, it helps us quantify the extent and severity of the injury, which then directly guides our treatment decisions and prognosis. X-rays are typically the first port of call, the most common initial imaging tests performed. Standard AP, front to back, and lateral side elbow radiographs are essential, and sometimes specific oblique views can be helpful too. Their primary role is to evaluate the bony structures, particularly focusing on the growth plates, the physes and apophyses around the elbow.
But you mentioned they can be normal initially.
Yes, that's a key clinical pearl here. Up to 85% of cases, especially in the early stages of simple apophysitis, may initially show completely normal growth plate findings on X-ray. The bone structure looks fine. Despite this, X-rays can still be incredibly informative, particularly if you look closely or get comparison views of the uninjured elbow. They might reveal important subtle signs such as physeal widening, where the growth plate space appears abnormally wider than the contralateral side, indicating inflammation or stress, pulling it apart slightly. They can also show early signs of fragmentation of the apophysis, or more dramatically, an actual avulsion of the medial epicondyle, where a piece of bone has been pulled away from the main humerus. The size and displacement of this fragment are critical factors. Occasionally, you might also see loose bone chips within the joint or other subtle bony injuries like stress fractures elsewhere in the elbow.
So X-rays are the baseline screen. When do you move to MRI?
Just exactly. When X-ray findings are inconclusive or perhaps negative despite strong clinical suspicion, or, importantly, if there are specific concerns about the integrity of the soft tissue structures, particularly the ulnar collateral ligament, then magnetic resonance imaging, MRI, becomes a crucial next step. MRI provides a far more detailed and exquisite view of both soft tissues, ligaments, tendons, muscles, cartilage, and bone, offering multiplanar imaging without radiation. It's invaluable for definitively confirming UCL insufficiency or tears, showing ligament thickening, thinning, or discontinuity. It can also detail the precise extent of edema or swelling within the medial epicondyle apophysis itself, which signifies inflammation and acute injury, even when the X-ray looks normal. And it's the best tool for accurately assessing the displacement of acute avulsion fractures if the X-ray is unclear.
And it can see other things too.
Yes, absolutely. Furthermore, MRI can detect other associated pathologies that might have been missed on X-rays, such as fluid collections within the joint effusions, synovitis, or those early signs of osteochondritis dissecans on the lateral side, providing a really comprehensive assessment of the entire elbow joint complex. So, to summarize, X-rays serve as our essential initial screen for bony injury and growth plate status, while MRI provides that definitive soft tissue detail and assessment of subtle bone injury, crucial for complex cases, preoperative planning, or when conservative treatment isn't working as expected.
Right, that clarifies the imaging pathway. Let's move on to treatment then. Once little lead elbow is diagnosed, perhaps confirmed with imaging, what is the initial foundational approach that clinicians should adopt?
Once the diagnosis of little league elbow is established, the initial and absolutely foundational approach is, without question, conservative management. This phase is really built upon the twin pillars of rest and a structured physical therapy program. The primary goals here are twofold. Firstly, to alleviate the immediate pain and inflammation, allowing the injured tissues the chance to heal, and secondly, to systematically address any underlying mechanical issues or deficits, whether it's poor throwing mechanics, muscle weakness, or inflexibility that contributed to the condition developing in the first place. It's fundamentally about breaking that cycle of repetitive microtrauma and fostering an environment for biological healing.
So what does rest actually mean in practice? Complete shutdown?
For the vast majority of cases, particularly medial epicondyle epiphysitis, yes, rest typically means complete cessation of throwing activities. This usually needs to be for a minimum of 4 to 6 weeks. This period of absolute rest from the aggravating activity is paramount to allow the inflammation to settle. Studies indicate that approximately 75% of patients with apophysitis were managed with this complete cessation of throwing. For medial epicondylitis specifically, that recommended 4 to 6 weeks of rest from throwing is absolutely crucial. However, it's worth noting that a smaller proportion, maybe around 25% of patients, particularly those with milder symptoms or perhaps just a strain, might be managed with relative rest. This could involve stopping throwing but continuing other conditioning, or maybe a position change, for example, an outfielder moving to first base temporarily provided these modified activities remain entirely pain-free.
And what about managing the acute symptoms?
In that acute phase, yes, adjunctive therapies are vital to manage symptoms. This typically includes the regular application of ice packs to the medial elbow for 15-20 minutes several times a day to reduce localized swelling and inflammation, and the judicious short-term use of non-steroidal anti-inflammatory medications, NSAIDs, like ibuprofen, can be helpful to control pain and reduce inflammation, particularly in the first week or two, but we tend not to rely on them long-term.
And the physical therapy component starts immediately.
Yes, concurrently, physical therapy is critical and ideally commences early on, even during the initial rest period, focusing perhaps initially on other parts of the kinetic chain. It begins with exercises designed to strengthen the musculature surrounding the elbow itself, but crucially also the entire shoulder girdle and core. The focus is not just on isolated elbow strength, but on addressing those global upper extremity and core strength deficiencies, alongside eventually refining throwing mechanics once pain allows.
What kind of exercises are typical?
The program typically outlines specific exercises. For example, wrist curls, flexion, and wrist extensions strengthen the forearm musculature. Strengthening those wrist flexors directly helps to offload the medial epicondyle during the acceleration phase of throwing, where those muscles are intensely activated. Pronation and supination exercises improve forearm rotation strength. Biceps curls and triceps extensions build general upper arm strength. And comprehensive shoulder exercises are absolutely essential things targeting the rotator cuff muscles and the scapular stabilizers, the muscles controlling the shoulder blade. These enhance overall arm strength, flexibility, and that vital dynamic stability needed for throwing. Each exercise is chosen for a specific biomechanical reason, aiming to protect and reinforce the vulnerable elbow joint.
How important is the support system around the athlete during this conservative phase? It sounds like compliance is absolutely critical for success here.
Compliance is, without any exaggeration, absolutely critical. And achieving it necessitates a truly collaborative effort from everyone in that young athlete's ecosystem. Coach and parent education is paramount. They need to understand the why behind the rest. It's crucial for limiting the number of innings pitched per week, or indeed pitches per game once throwing resumes, and ensuring strict adherence to all the rest guidelines during the recovery phase.
It must be hard sometimes with pressure to play.
Incredibly hard. If the athlete, their parents, and their coaches are not fully on board with the rationale behind the rest and the very gradual activity modification, the risk of re-injury or a significantly prolonged recovery, or even non-recovery, dramatically increases. It's often a challenging conversation, especially given competitive pressures and aspirations, but it's one that absolutely must be had, clearly and firmly. It's also important to note that while rest from throwing is key, prolonged, rigid immobilization is generally avoided unless there's a specific indication, like a significantly displaced fracture requiring casting. For most cases of apophysitis, we prefer minimal immobilization. We want to maintain elbow range of motion and prevent stiffness. So the athlete usually isn't in a cast or rigid brace for weeks on end. This balance of targeted rest while maintaining overall mobility is delicate but crucial for optimal recovery.
Okay, so conservative management is the mainstay. But when does that prove insufficient? And what are the more aggressive or operative options available for Little League elbow? This is where clinicians might need to start considering different pathways.
That's right. While most cases, especially apophysitis, respond well to that structured conservative approach, there are scenarios where initial non-operative management doesn't yield adequate improvement despite diligent adherence. Or sometimes the initial injury is severe enough to warrant considering other options sooner. In terms of regenerative medicine, techniques such as prolotherapy, or more commonly now, platelet-rich plasma, PRP injections, or even stem cell therapy are increasingly being explored, although their role is still evolving, particularly in skeletally immature athletes.
How does something like PRP work here?
Well, platelet-rich plasma, PRP, involves drawing the patient's own blood, concentrating the platelets, which are rich in growth factors, and then injecting this concentrate directly into the injured area, perhaps the inflamed apophysis or a partially torn UCL. The theory is to amplify the body's natural healing cascade by delivering a high concentration of these signaling molecules right where they're needed. These techniques might be considered if there is significant persistent soft tissue damage, perhaps a chronic UCL sprain that just isn't fully healing with rest and therapy, or maybe in select cases of osteochondritis dissecans with ongoing pain and limited healing potential shown on MRI. However, their widespread application in Little League elbow, especially in growing children, requires more robust long-term evidence. They're not a first-line treatment currently.
And when does surgery come into the picture?
Surgical intervention is truly positioned as a last resort in the management of most Little League elbow conditions. It's generally only considered, after all, non-operative and less invasive treatments have demonstrably failed to resolve symptoms or restore the athlete's functional capacity, or are, in cases of acute significant structural damage like a displaced fracture. There are two primary surgical indications relevant to the Little League elbow spectrum. Firstly, open reduction internal fixation, or IIF, of the medial epicondyle. This is specifically indicated for those medial epicondyle avulsion fractures, where the bony fragment is significantly displaced, typically more than, say, 2 to 5 millimeters of displacement, or if there's any concern the fragment is trapped within the elbow joint causing impingement.
So putting the bone back and holding it.
Exactly. If that piece of the growth plate has been pulled away and is significantly displaced, it needs to be surgically put back in its anatomical position, reduction, and then fixed, often with pins or screws, internal fixation, to ensure proper healing, reestablishment of bone integrity, and to avoid long-term issues like deformity, non-union, failure to heal, or functional deficit. Secondly, ulnar collateral ligament UCL reconstruction, widely known as Tommy John surgery, although less common in the very young LLE population compared to older adolescents or adults. This is indicated for cases of chronic UCL disruption and symptomatic insufficiency.
Meaning the ligament is just too damaged to work?
Precisely. This means the ligament is either completely torn or so lax and attenuated from repetitive microtrauma that it can no longer adequately stabilize the elbow against that valgus stress during throwing. This leads to persistent pain, instability, and usually a complete inability to throw effectively at competitive speeds. It's important to note that the techniques for pediatric or adolescent UCL reconstruction are largely similar to those used in adults, often employing an autograft tendon, frequently the palmaris longus tendon harvested from the patient's own forearm to reconstruct the damaged ligament. The decision for surgery in any young athlete, particularly something like a UCL reconstruction, is always made meticulously. We have to consider the skeletal maturity, the severity and chronicity of their symptoms, their compliance history, and crucially, their future athletic goals and the realistic expectations surrounding the very extensive and lengthy rehabilitation required postoperatively. It's a major undertaking, and patients and parents need comprehensive counseling on the commitment involved. It's certainly not a quick fix.
Definitely sounds like a significant undertaking. So, Beyond that initial rest and potential advanced interventions, what does a truly structured and effective rehabilitation program for Little League elbow entail? This seems absolutely critical for long-term recovery.
Absolutely. A truly structured and effective rehabilitation program is the cornerstone of successful recovery, whether managed conservatively or postoperatively. And it's anything but a one-size-fits-all protocol. It needs to be profoundly individualized. It starts, as always, with an accurate diagnosis to pinpoint this specific underlying pathology. Is it apophysitis, a UCL sprain, GIRD contributing? This precision allows the therapy team to address the precise root cause of the symptoms, not just the symptoms themselves. Taking a thorough history of the athlete's practice and game schedules, their training intensity, their overall health status, any previous injuries, that's all essential input. This informs the tailoring of an appropriate and realistic program, taking into account their unique demands, their skeletal maturity, and their body's capacity for recovery.
What are the key stages or phases of rehab?
The rehabilitation typically progresses through several key, carefully graded stages. Initially, especially if there's significant pain, the focus might be on modalities to reduce elbow pain and inflammation. This could involve continued icing, perhaps therapeutic ultrasound or electrical stimulation, alongside passive range of motion exercises, gentle stretches, and manual therapy techniques aimed at pain relief before active strengthening and functional rehab fully commences. The core of the program then shifts to addressing the underlying dysfunction or pain generators. As we discussed, this almost always involves a detailed biomechanical analysis of the throwing motion if possible. Identifying and correcting improper mechanics like poor trunk rotation, leading with the elbow, arm drag, insufficient leg drive is absolutely fundamental to preventing recurrence. This often involves close collaboration between the therapist and a knowledgeable pitching coach or movement specialist.
Okay, fix the mechanics, then what?
Following this, the emphasis moves firmly onto the restoration of full, pain-free range of motion, ROM, in the elbow joint. It's crucial to regain complete flexion and extension, as well as forearm rotation, without any pain or restriction, ensuring normal joint mobility. Concurrently, and just as importantly, we work on establishing dynamic shoulder stability. A strong, stable shoulder girdle is vital for efficiently transferring forces up the kinetic chain and protecting the elbow downstream. This involves intensive rotator cuff and scapular stabilizer strengthening. This is then followed by the implementation of a progressive strengthening program designed to systematically regain strength, power, and endurance in the shoulder blade musculature, the core, and the elbow forearm muscles themselves.
And you mentioned concentric and eccentric exercises.
Yes. As recovery progresses, we systematically integrate both concentric and eccentric resistive exercises. Concentric exercises involve muscle shortening as it generates force, like lifting a weight during a bicep curl. Eccentric exercises involve the muscle lengthening under tension, like slowly lowering that weight. Both are essential. Eccentric strength, particularly in the forearm flexors and shoulder decelerators, is crucial for controlling the arm during the follow-through phase of throwing and protecting the joint. The entire program must be guided by pain and symptoms. Progression to the next stage or increased intensity occurs only when the athlete is consistently pain-free at the current level. It's a criteria-based progression, not just based on time.
That sounds very comprehensive. So what should patients, parents, and indeed clinicians realistically expect regarding the recovery timeline for Little League elbow? It must vary considerably depending on the severity and the treatment path.
You're absolutely correct. Recovery timelines for Little League elbow do vary significantly. There's no single magic number. The duration is highly dependent on the specific injury severity, simple apophysitis versus a UCL tear, for instance, the specific pathology identified. And crucially, the athlete's unwavering adherence to the prescribed treatment and rehabilitation plan. Compliance is probably the biggest variable factor. Managing expectations accurately is a vital part of the clinician's role here.
So for a typical apophysitis case managed non-operatively,
In most common cases involving medial epicondyle apophysitis, which is typically managed conservatively with rest and rehab, young athletes can generally anticipate returning to throwing activities after completing that structured rehabilitation program. This typically takes, on average, up to about 12 weeks from diagnosis to return to sport. We have clinical data suggesting the median return to sports was indeed 12 weeks from the point of diagnosis, but with an interquartile range stretching from 7 weeks to 18 weeks. This highlights that while 12 weeks is a reasonable median expectation, there's natural variability. Some might recover faster, others, particularly if there were kinetic chain issues like GIR, might need a bit more time.
and for the more severe cases, maybe requiring surgery.
Yes. For more severe cases, particularly those requiring surgical repair, such as a significantly displaced medial epicondyle avulsion fracture needing ORF, or certainly a UCL reconstruction. The recovery timeline is substantially longer and more involved. This could potentially range from maybe 6 weeks to start very light activity after a straightforward bony repair where early mobility is encouraged, but it often extends to 6 months, or even a full year, or sometimes more, following a complex UCL reconstruction before a return to competitive pitching is feasible. The exact duration depends heavily on the complexity of the injury, the specific surgical procedure performed, and again, the meticulous adherence to the often very lengthy and rigorous postoperative rehabilitation protocol, which is usually phased over many months. We must counsel patients and their families very clearly that choosing a surgical pathway represents a very significant commitment in terms of time and effort.
So recovery is one thing, but what does this all mean for long-term athlete health and, crucially, preventing recurrence? It sounds like vigilance is required even after initial symptoms resolve and they've successfully returned to play.
Yes, long-term athlete health and, perhaps most importantly, preventing recurrence are paramount considerations. And achieving this truly hinges on sustained periods of appropriate rest, load management, and ongoing diligent monitoring, even after a successful return to sport. A general rest period of at least 3 to 6 months per year away from overhead throwing is often recommended for the overall health of the throwing arm, particularly after a significant Little League elbow diagnosis. This isn't just about the elbow healing initially. It's about allowing the entire upper kinetic chain to fully recover, remodel, and avoid chronic overuse patterns. This means having a defined off-season. For medial epicondylitis specifically, after that initial critical 4 to 6 weeks of complete rest from throwing, the return to activity must be very gradual and closely supervised, following a structured interval throwing program.
What should they do during rest periods?
During mandated rest days within the season, and certainly during the off-season, it's vital that athletes continue to engage in non-overhead sports and general conditioning exercises. This helps maintain their overall fitness, strength, and athleticism without repetitively stressing the vulnerable elbow structures. It keeps them active and engaged while allowing the specific throwing tissues to heal and recover. Cross-training is key.
And the risk of it coming back.
The risk of recurrence is unfortunately a very real concern. Clinical data indicates that around 13% of patients experienced a recurrence of elbow pain at a median of 24 months, 2 years following their initial diagnosis. What's particularly notable, perhaps predictive about this subcohort who had recurrence, is that they had a significantly longer duration of symptoms prior to their index presentation, with a p-value of 0.024.
So delaying treatment increases recurrence risk.
It strongly suggests that yes, delays in seeking appropriate treatment, or perhaps a failure to comprehensively address all the contributing factors, like mechanics or GRD, early on, can unfortunately lead to a higher propensity for the condition to return down the line. We also have well-documented case reports, for example, of a patient who suffered a subsequent medial epicondylar avulsion fracture specifically due to non-compliance with recommended rest and attempting an early, unsupervised return to high-intensity throwing.
A cautionary tale.
A very stark cautionary tale. It underscores the critical importance of patient and family education, adherence to the treatment plan, clear communication between the medical team, coaches, and family, and continuous monitoring of symptoms even after return to play. Any return of pain, even if mild, must be addressed promptly and taken seriously to prevent a more severe re-injury. You can't just assume it's gone forever.
So how do we safely and progressively guide these young athletes back to competitive play without risking that re-injury? It sounds like there needs to be a very deliberate, highly structured return-to-play protocol.
You're absolutely right. A highly structured, meticulously phased return-to-play RTP protocol is not just recommended, it's absolutely essential for a safe and durable return. This protocol must be meticulously tailored to the individual athlete, considering their specific position, pitcher versus fielder, their current skill level, age, and of course the precise severity and type of their initial injury. It cannot be a generic checklist applied to everyone. Before even contemplating initiating any throwing activities as part of the RTP, several key prerequisites must be met without exception. The athlete must be entirely pain-free, both at rest and with all provocative clinical tests. They must have achieved full, unrestricted, pain-free range of motion in the affected elbow and shoulder complex.
What about mechanics?
Crucially, engaging in functional assessments of their throwing mechanics is also vital at this stage. We need to ensure any biomechanical flaws identified earlier have been comprehensively corrected through their rehab and coaching, and that they can now execute the throwing motion efficiently without compensatory movements or excessive strain on the elbow. This often involves slow-motion video analysis to confirm correct sequencing and form.
Okay, pain-free, full ROM, good mechanics. Then what?
Once these prerequisites are fully satisfied, a systematic progressive interval throwing program can typically be initiated. This usually begins after that recommended 4 to 6 weeks of complete rest have elapsed for standard apophysitis cases. Longer post-surgery, obviously. The program involves a very gradual, step-by-step increase in throwing distance, intensity, effort level, and volume, pitch counts. It starts with very short, light throws, often from a stationary crow hop position, and progressively builds up over several weeks, eventually incorporating pitching off a mound at increasing intensity and volume, mimicking the escalating demands of competitive play. Throughout this entire process, meticulous monitoring for any signs of pain or discomfort is paramount. The athlete, parents, and coaches must be educated on this. If pain recurs at any stage, the athlete must immediately stop, rest, and step back to the previous pain-free level in the program. The progression must then be reevaluated, potentially slowed down, to identify why the symptoms returned. This slow, controlled, symptom-guided progression is the safest and most effective way to gradually rebuild tissue tolerance, strength, endurance, and confidence without risking re-injury. It requires significant patience and strict adherence from the athlete, parents, and coaches alike. Rushing this phase is a recipe for disaster.
Prevention really does seem to be the ultimate goal here, avoiding getting to this stage in the first place. What are the critical elements of effective injury prevention for Little League elbow?
Indeed, prevention is paramount, absolutely. And it fundamentally begins with implementing effective training techniques and, perhaps more importantly, cultivating a culture of smart play and long-term athlete development from a very early age. Coaches play an absolutely pivotal role here. They must guide young athletes to prioritize learning and mastering proper throwing mechanics from the moment they start playing. The overarching goal must be to minimize undue stress on both the shoulder and, crucially for this discussion, the elbow joints. This means tirelessly emphasizing proper body rotation, generating power efficiently from the ground up, using the legs, hips, trunk, and core, rather than allowing youngsters to rely excessively on just their arm strength to generate velocity. When the arm does too much of the work in isolation, it creates harmful and unnecessary torque on that vulnerable developing elbow. Good coaching is key.
What about strength and flexibility?
Yes. Beyond mechanics, advocating for the integration of age-appropriate strength training and flexibility routines, specifically tailored to the demands of the athlete's sport, baseball, tennis, etc., and position, is crucial. These programs, when designed correctly, can significantly improve muscle performance, enhance dynamic joint stability, and increase the overall resilience of the athlete's entire musculoskeletal system. For example, as we've touched upon, athletes with strong core muscles are generally less prone to injuries, as robust core stability provides that crucial foundation for controlling trunk rotation and protecting critical areas like the shoulder and elbow during dynamic physical activities like throwing. Also, simple but often overlooked elements like incorporating specific dynamic warm-up routines before any throwing session and performing thorough cool-down stretching routines afterwards contribute significantly to injury prevention by preparing the tissues for activity and facilitating recovery afterwards. They should be skipped.
We hear a lot about pitch count guidelines. You mentioned them earlier. What are the current recommendations and what are the real-world challenges in ensuring consistent adherence to them?
Pitch count guidelines are absolutely vital. They form a cornerstone of evidence-based prevention. Strictly following age-specific pitch count guidelines and the associated mandated rest days is non-negotiable for protecting young arms. Organizations like Major League Baseball's Pitch Smart program and similar initiatives globally provide clear, evidence-based recommendations. These are typically based on a pitcher's age, and they outline maximum pitch limits per game or day, and importantly, the required number of rest days based on the volume of pitches thrown in an outing.
Can you give an example?
Sure. For example, a 9-10-year-old pitcher might be limited to, say, 50 pitches in a day and require 2-3 days of rest afterwards, depending on the exact count. Whereas a 15-16-year-old might have a higher daily limit, perhaps 95 pitches, but still requires specific mandated multi-day rest periods based on hitting certain thresholds. These guidelines are scientifically designed to protect those developing growth plates and soft tissues from dangerous cumulative stress.
But are they followed? What are the challenges?
That's the crux of it. We face significant and persistent challenges with inconsistent compliance in the real world. This is particularly true during highly competitive tournaments or showcase events, where there might be immense pressure, sometimes overt, sometimes subtle from coaches, parents, or even the athletes themselves, to push beyond safe limits for the sake of winning or gaining exposure.
the pressure to perform.
Exactly. Therefore, educating athletes, coaches, and parents about the why behind these recommendations, clearly explaining the direct physiological link between overuse, fatigue, and increased injury risk is absolutely crucial for achieving better adherence and, consequently, lower injury rates. It's not enough to simply publish the guidelines. They must be understood, valued, and consistently enforced by everyone involved in the young athlete's development, even when it means making difficult decisions like pulling a pitcher early.
How can external support, maybe like personal trainers and broader educational initiatives, contribute to creating a safer environment overall for these young athletes?
External support and broad educational initiatives are absolutely vital complements to individual efforts and team coaching in any comprehensive prevention strategy. For instance, engaging qualified personal trainers, ideally those with specific experience and certification in youth sports, performance, and injury prevention, can be incredibly beneficial. These professionals can develop customized, age-appropriate training programs focusing on building strength, improving flexibility, enhancing core stability, and refining movement patterns specifically tailored for injury prevention in young throwers.
How would they help specifically?
Well, they can help reinforce proper biomechanics, learn from coaching, identify and address potentially harmful muscular imbalances or flexibility deficits before they become problematic, and ensure that the athlete's entire kinetic chain is functioning optimally: strong legs, stable core, mobile hips, stable scapulae. As we discussed, a strong core protects critical areas, and trainers can explicitly target this. They can also introduce specific injury prevention techniques that might be overlooked in standard team practices, such as targeted dynamic warm-up routines, effective cool-down strategies, and perhaps even functional movement screens to identify individual areas of weakness or inflexibility that predispose to injury.
And the wider education piece.
Beyond individual training, comprehensive education for coaches and parents is absolutely paramount, perhaps the most critical piece. Coaches need to be fully aware of and committed to safe practice guidelines and pitch count limits. They need to understand the importance of prioritizing long-term skill development over simply winning at all costs, especially at younger ages. And crucially, they need training in how to diligently monitor for those subtle signs of fatigue in young athletes. Things like dropping the elbow, decreased velocity, loss of control, because fatigue is such a direct precursor to poor mechanics and subsequent injury. Parents also play an absolutely critical role. They need to foster an environment where their children feel empowered and encouraged to listen to their bodies and to communicate any pain or discomfort honestly, without fear of letting down their team, their coach, or their parents. This helps them learn to self-regulate and avoid overtraining, which is such a significant precursor to overuse injuries like Little League elbow. Frankly, this education and culture shift is often where the real battle lies, isn't it? I've seen countless cases where a talented young pitcher, maybe with a championship game coming up, decides to push through that little bit of soreness, only to turn a minor apophysitis into a season-ending, sometimes career-altering injury like an avulsion fracture or a significant UCL tear. It's a constant challenge requiring vigilance and education. Ultimately, the key in the effective treatment of Little League elbow is, in fact, prevention. And this responsibility lies not only with the evaluating orthopedic surgeon or team physician, but also critically and collaboratively with the coach, the athletic trainer, the physical therapist, the parents, and even the league officials. It truly requires a collective, concerted effort to safeguard the long-term health and athletic potential of these young athletes.
Professor, that has been an incredibly comprehensive and genuinely insightful deep dive into Little League elbow. Thank you. Just to recap for everyone listening, we've really learned that Little League elbow isn't one thing, but a complex, multifactorial overuse injury spectrum predominantly affecting young male throwers. It demands a truly holistic approach, from precise diagnosis considering the whole kinetic chain, through tailored, often conservative management focusing on rest and rehab, to, most critically perhaps, robust preventive strategies that absolutely must involve everyone in that young athlete's ecosystem.
It truly is a multifaceted challenge, yes, and one that demands our ongoing attention and research. Understanding its nuances, as we've discussed, is absolutely essential for effective intervention and, much more importantly, for prevention.
Indeed. And to our listeners, as medical professionals on the front line, we really encourage you to integrate this comprehensive understanding into your clinical practice. Perhaps challenge yourselves and those you work with to be proactive advocates for injury prevention in youth sports. Emphasizing that collaborative role across the medical, coaching, and parental spheres is so vital if we're to safeguard the long-term health and athletic potential of our young athletes. If you found this deep dive valuable today, please do consider leaving us a rating or sharing it with a colleague who might also benefit from these insights.
Yes, it's a topic that truly demands our collective effort, sharing knowledge to protect our future athletes.
Thank you again, Professor Moimam, for your invaluable expertise and insights today. It's been incredibly informative. And to you, our listener, thank you for joining us on this Deep Dive Ortho. We look forward to our next in-depth discussion.